Hello, sir. Ravichandran, sir.
Yes, boss.
Yes, sir. Shall we begin the session? It's sharp 11. Okay.
We'll begin section. I'll just introduce our first guest speaker today. Good morning, everyone. Myself, Dr. Dharmishta Kapadia. I'm assistant professor in MGMCRI. So thank you for being here on this morning. Today we are pleased to welcome Professor Dr. C. Ravichandran, a very special guest from Madras Medical College, Chennai. Professor Dr. C. Ravichandran is currently working as a professor and head of Department of Pediatric Hemato-Oncology. Sir did his MBBS from Madras University, DCH from Bangalore University, and MD Pediatrics from Dr. MGR Medical University. He served as a professor for more than 10 years at various government institutes. He has specific interest in community pediatrics, hemato-oncology, and neonatology. He was training coordinator, IMNCI Nodal Center, Tamil Nadu, and UNICEF Health Specialist, Northeast State in Bihar, Chennai, and in Kerala. He is actively participating in various state and national level programs and currently as a member of expert committee for pediatric and hemato-oncology guideline for pediatric COVID diseases, Government of Tamil Nadu. He is actively involved in various research programs funded by government organizations and UNICEF. He has conducted various state and national level training programs for neonate and childhood illness management. He has been awarded with many prestigious awards for best paper at state and national level conferences and active pediatrician award by Indian Academy of Pediatrics. He served actively in Indian Academy of Pediatrics. So with this note, I would like to thank you, sir, and welcome you. And we'll be looking forward for your expert opinion on approach to child with leukemia. Sir, you can start your session.
Yeah. Thank you for the kind introduction. For the next maybe around 30-35 minutes, we would be it will be about leukemia in general as such, and then probably we can take the questions and the answers would be given, provided they are within my purview. And let me start by thanking the organizers for having invited me for this program. I think when I saw the virtual invite, I was a bit surprised because I am the only clinician. I think the whole thing is a pathology conference as such, and so it is a great honor to be part of a pathology conference as a clinician. So both pathology and clinical subjects actually are the two sides of the same coin as such. So both of us need each other to treat the patients to the satisfaction of the patient and to the satisfaction of us. And so I think it would be that way a good beginning to have this kind of interactions. So with that, let me go straight to the subject as such. Now, whenever we talk about, let us say, a condition, we always start with definition. And that has become what you call the norm as such. Now, is it difficult to define a leukemia? In a sense, yes. In the sense that blood cancer is a very vague term as such. And so, if the cancer is in the blood, so in which organ is it? So, this kind of issues do come up. So, for the purpose of the postgraduates and for us, we define it as cancer of the blood, the bone marrow, wherein there is an abnormal increase of immature white blood cells, and these cells are called as blasts. It is part and parcel of a broad spectrum of disease, in fact. Actually, they come under the conditions called as hematological neoplasms, which include the diseases affecting the blood, the bone marrow, and the lymphoid system. And all these three together are called as the hematological neoplasms. And we also usually call it as liquid tumors. Unlike the solid tumors which arise from the liver, the other, what do you call, the solid organs. And this is a flowing tumor, and so we call it as a liquid tumor. So again, as usual, all the diseases are classified. This is clinical classification. I am not going into the pathological classification, which consists of FAB systems, the WHO system, and all that. For us, it is simple. How long has the cancer been present, and what are the cell line characteristics? So if the cancer has been present for quite some time, then it is most likely to be chronic. And if it is something which is presented very acutely in a very short time, then we call it as acute. And then based on the cell lines and the origin, either it is from the bone marrow or is it from the lymphocytes. And mind you, the lymphocytes are present both in the bone marrow as well as in the lymph nodes, the lymphoid systems as such. Okay. So the myeloid stem cells give rise to monocytes, macrophages, erythrocytes, megakaryocytes. While the acute lymphoblastic leukemia occurs when there is a proliferation of the lymphoid stem cell. And the AML or the acute myelogenous leukemia occurs when there is a malignant proliferation of the myeloid stem cell. This is in simple. So if you look at it, that means we have two lymphocytic and two myelogenous groups. The acute lymphocytic, the chronic lymphocytic, and then the acute myelogenous and the chronic myelogenous. And for all practical purposes, chronic lymphocytic is something which is never seen in children, and so we will not even consider it here, excepting for comparison of the presentations as such. So this is the simple classification which we use in the clinical terms as such. So what is the difference between the acute and the chronic leukemia in that case? So both of them arise from the immature cells. In acute leukemia, it is immature. It is not yet matured as such. While in chronic leukemia, the cells do mature, but they do not function normally as such. That is the important criteria. So this is just a screenshot of the what do you call the normal hematopoiesis as such. So you will see that there is a pluripotent stem cell, and then it differentiates into lymphoid stem cell and the myeloid stem cell. And the lymphoid stem cells give rise to the B cell and T cell, while the myeloid will again further differentiate into the different types of blasts, namely the basophilic erythroblasts, which goes on to become the orthochromatic, and then further probe and normoblast and all, and then comes to a reticulocyte, and then ultimately matures into an erythrocyte without any nucleus. The megakaryocytes are from the megakaryocytes give rise to the thrombocytes or the platelets as such. Then we have the eosinophilic myeloblast, which goes on to provide the eosinophils. The basophilic myelocytes, the basophils, and the monocytic again divides into two. One is the monocytic and the other one is the neutrophil as such. So this in short is all about the hematopoiesis, and the problem is here and here. If you look at it, with the leukemia, it is either here or here as such. So again, just to summarize, blast cells are immature precursors of either the lymphocytes or the granulocytes, and generally they should not be present in the blood. If they are present in the blood, that means there is no space in the bone marrow as such. So conditions where the bone marrow is fully replaced would be either a malignant proliferation, or the whole marrow has become, let us say, occupied with something else, so much so that the normal blast cells and others enter into the periphery. The classical example of such thing would be our brittle bone disease, where you will see that the entire marrow is replaced with the very brittle bone, and so the marrow has to be out, and so you get that. The presence of blast in the blood usually signifies leukemia, but we have to keep in mind that in myelofibrosis and conditions like this, you may have a replacement of the marrow with fibrosis, or so they may be present. So we need to keep that in mind. Otherwise, presence of blast in the periphery is a diagnostic sign of leukemia. In a bone marrow, normally about 20% of the blasts are usually present. So anything beyond 20% should be considered as suggestive of a malignant clone. And how to differentiate between the two blasts, the lymphoblast or the myeloblast, it becomes a bit difficult. So if you can see or rods, or if you can see granules, then you are likely to make a diagnosis of acute myeloid. Have I been muted? Yeah. Now am I audible, please?
Sir, you are audible, sir. You are able to see your screen also.
No, because suddenly I got a message saying that you are muted. Thank you. So the myeloblast is usually identified by the presence of other, as I told you, the other precursors of the mature cells do appear in the marrow in large numbers, like your band forms and others. And so this would help you in differentiating whether it is acute myeloid or acute lymphocytic. So a little bit of about why should we know about this leukemia? Is it such a common disease? If you look at it, it is the most common of the childhood cancer. If you see 3 children with cancer, one of them would definitely be a leukemia. But overall, among the childhood leukemia, among the children, cancer is very rare. So that way, it is not such a common condition as we all expected. But then, if I tell you that 43,000 children per year are diagnosed of having leukemia every year, you can look at the magnitude. The what do you call, the percentage of prevalence varies depending on where they come from. There are certain regions in the country where it's a bit more seen, but otherwise generally we do get about 150 to 100, anywhere between 150 to 175 cases of leukemias per year in our institution. And the cancer registry of Tamil Nadu says that there are roughly about 1% of all the children do suffer from leukemia. 1% in an 8 crore population is a huge number. Of the leukemias that come to you, the chances are that 85% of them would be ALL and 14% would probably be AML, while 1% is likely to be chronic myeloid leukemia. So there is also an age predisposition as such. The younger the age, it is more likely to be ALL, while with AML, there is a widespread. You are likely to see it from the, let us say, from birth onwards, right up to about, as I say, about pediatrics, about 18, 19 years. But the incidence slightly peaks in the first 2 years and during the teenage group in the AML as such. Now, this is a common question which every mother asks me. Now, there is no family history of cancer in our house. Why should we get it? Most difficult question to answer, and most difficult to explain this. Why cancer should occur in an individual, and that too in a very young child. Imagine a child coming at 6 months, and then if you tell them that they have cancer, the first question they ask is, did she get it from any of us? And the second question they ask is, why my child? Why not some other child? Okay. So we can only theorize. We do not exactly have this thing. We know that mutations do occur in the DNA. Now, why these mutations occur, we do not know. We know that there are oncogenes which are activated. We also know that there are suppressor genes which actually suppress the oncogenes, and these can be deactivated. So what actually causes them is something which has been under what you call active research. We still do not know the answer. There is a genetic predisposition towards leukemia. Does it occur in all? As such, children having leukemia, as we told you, is not very common among the general population as such. But wherever we already have two families, in fact we have three families now. The last one was the brother had ALL. He was treated for BALL, fully recovered, and his sibling now is under treatment for BALL again. So that may be a genetic predisposition as such, because there are families, and the literature is full of them. Then the third concept is all about viruses. Are we looking at a lymphotropic virus causing it? Yes. With adults, there has been an increased association between T lymphocytic lymphotropic viruses with the adult T cell leukemia. In children, not exactly. The Hiroshima, Nagasaki, and the multiple nuclear leak from the Chernobyl and other areas did show that when the radiation doses are very high, there is a definite increase in the risk of cancer, both in the animals and in the people. So we know that radiation does have an effect. Non-ionizing radiation, again, it has been proposed that high levels of extremely low frequency magnetic field energy can cause leukemia, but then how many of us are exposed to this extremely low frequency magnetic field, considering that the entire earth itself acts as a magnet, something which we need to look at. So what are the genetic conditions where we can suspect a childhood leukemia occurring? I think all this is well known to you as such. Downs, Fanconi, Bloom, Diamond Blackfan, Schwackman, and then Klinefelters, Turners, neurofibromatosis, ataxia telangiectasia, and then we have SCID, severe combined immunodeficiency, with paroxysmal nocturnal hemoglobinuria, and then Lee-Fraumeni. So for this, we have evidence. We have been having cases with Down syndrome. Right now we have about 3 cases. I have neurofibromatosis with the JMML, again 3 of them. The parents have neurofibromatosis, and in this child you can see Cafale spots. And severe combined immunodeficiency, we had 2 children, and both the children we lost recently to COVID. Environmental factors predisposing to childhood leukemia, just keep it in mind that if a child comes from this kind of area where they're exposed to an ionizing radiation, and then where they are exposed to drugs like alkylating agents, history of having taken alkylating agents, nitrosourea, epiphotophyllotoxins, or benzene exposure, as in the case of pains and benzene inhalation, then yes, there is a possibility of a leukemia. Advanced maternal age is something which again has been found to be increasingly associated with childhood leukemia. This is an association, whether it causes it, we don't know. So if you look at the pathophysiology, it is just simple that an immature blast cell, for reasons best known to itself, mutates, and so goes into what you call autonomous not being under the control of cellular apoptosis or the bodily mechanisms, and just simply multiplies. And when these cells multiply, they do 2 things. They deplete the nutrients of the normal cells and thereby cause the apoptosis of those cells. And the second thing is they simply actually replace all the normal marrow cells by just proliferating and occupying those areas. So when you have these kind of huge numbers, they will result in metabolic complications, and these blast cells, mind you, cannot perform their primary function for which they were destined, namely preventing infections, controlling bleeds and all. And so you have this problem. So if you know this, then it becomes easy to ask for the question. So anemia, neutropenia, thrombocytopenia, they are all bone marrow failure syndromes. So any child who presents to you with the sudden increase in progressive pallor and then a fatigue, or the child feels that he is not able to play, and mother says that he has fever from which he fully does not recover, and then infections which they never thought would happen keep happening, and they have multiple mouth ulcers. With when they brush in the morning, they find that there is always a little bit of ooze of blood, sometimes oozing from the nose, namely the epistaxis. Then they have easy bruisability. They will have ecchymosis, and then petechiae appearing in the skin. So if you have this kind of a picture, then, and with the complaining of pain, a child who says that even in the night he has such severe bone pain, he doesn't want to play because of the pain, then you should keep in mind that you are looking at a possibility of a leukemia. And then I told you high blood counts, hyperleukocytosis. So whenever this occurs, the blood becomes thick, leukostasis occurs. So this can produce visual changes. They may have, they may say that they have blurring of vision, they will have constant headaches, they are very irritable. And whenever there is other organ infiltration, the commonest organ to be infiltrated would be the lymph nodes, the the liver, the spleen. And we have had cases where only renomegaly was the clinical presentation, and no cells in the no peripheral blasts. And then we also did the marrow, and marrow did not. After all, in marrow we are taking a small part, and so you have to be persistent. If you have a renomegaly, unexplained renomegaly, it could be that that organ is also infected. And then into the brains, producing papilledema, and then behavioral disturbances and increased ICP because of bleeds sometimes and because of infiltrations, and then paralysis, individual nerve involvement, and then painless testicular enlargement. All these could be signs of leukemia. Mediastinal mass is something which usually presents, and whenever a child comes to you with stridor, respiratory distress, and then you feel that the veins of the neck are all enlarged, and there is a diffuse congestion of the eyes, and the face appears a bit edematous, you are probably looking at superior mediastinal syndrome, and probably you're looking at a lymphoma or a leukemia. T-cell leukemias usually present like this. So T-cell leukemias and lymphomas usually present with a mediastinal mass. You take an X-ray, you will find a huge mediastinal mass, and then you do an ultrasound, you will see multiple mediastinal nodes. So whenever you have this kind of high cellular proliferation, and this leads to the death of the particular what you call the tissue in which it has infiltrated, you will have bone and joint pains because of the stasis in these small vessels, the muscle weakness and constipation. So in our case series, which we have, we found that most of them have a history of fatigue. It's not that only one symptom is present. Usually it is multiple symptoms. And the commonest thing is that they are fatigued and they are also irritable with bone or joint pain. So you have these two. Always keep in mind a leukemia and a rheumatological condition. Mind you, many a time it is diagnosed as rheumatological, and then somebody starts on steroids, so the blasts disappear, and then persistent thrombocytopenia. And then when they come to us, once the steroid is stopped, then a month later you find the blast. We have had 7-8 cases for this year alone that way. So fever is present in about 71%, and then purpura and weight loss are roughly the same way, around 50 to 60%. Hemorrhage into the what you call life-threatening hemorrhages, like in the case of yesterday we lost a child. He had a huge hemorrhage. That was the only history. Intracranial hemorrhage, otherwise fine, normal, no fever, not just a fever of 2 weeks back. and the mother did not notice anything. And then when we did a peripheral count, his counts were 2 lakh plus, and he had a huge bleed in the brain, intracerebral hemorrhage, and he came at a very late stage. So, but considering that of all the presentations, hemorrhage is around 27%. But mind you that 27% of the leukemias bleed, and look at the children who come to you with bleeds, they are very rare. So could be a significant history. So typically this is something which I picked up from somewhere, I don't know, but it is a wonderful picture. So this is how it is. The child comes with bleeding, infection, lymphadenopathy, and look at his face, and the bones keep crying that it hurts. So simply put all the clinical problems together, it is very simple. Look for signs, evidence, history of bone marrow failure, anemia, neutropenia, thrombocytopenia. Look for infiltration signs, which means you are looking at hepatosplenomegaly and then chloromas, sarcomas. Lymphadenopathy is there. In the testis, individual nerve palsies, and of course meningitis and these conditions. Hyperleukocytosis, where they come to you with stroke or ARDS, acute respiratory distress. Nothing, no finding, excepting that he has got unusual respiratory distress, cause not known. Look at the picture, it shows in evidence something like an ARDS, and then you do the counts, you find that they are in lakhs. And metabolic complications. The metabolic complications, as I told you before, are because of the huge load, and so you have hypercalcemia, hyperkalemia, hyperuricemia, hyperphosphatemia, and of course hypercoagulable because of the thick blood acid. So I try to put everything together in a tabular column. It is just that there are only two things which you need to know in all this. The signs and symptoms are all the same. The hemoglobin is usually low and maybe normal in some, but the thing is that if you see in the case of chronic, the white blood cell counts are very, very high as such, and the platelets are normal. While in case of ALL, acute conditions, they may be high, the white blood cells may be high, or it can be pancytopenia, but the platelets are always low. So if you have a thrombocytopenia, always have a very high index of suspicion. And the bone marrow would show 20% plus blasts in case of acute, while in chronic, as I told you, they all mature, but they are functionally not, they are not useful, and so they will not have any blasts in the bone marrow as such. Even in the CML, the presence of blast is just about less than 10%, and so the rest depends on the infiltration and how much has the infiltrated process. So how to approach the child? You need to have a very diligent history. You will have to be very patient, asking all the questions regarding those 4 syndromes which I have told you, which means bone marrow failure syndromes, and then hyperleukocytosis syndromes, infiltration symptoms, and hypermetabolic symptoms. So once you have got the history, if you have very high counts, then there may not be a need for doing a bone marrow assessment. But what is important is that you have to do a CBC and you have to do a peripheral smear. Do not stop only with CBC. CBC will not give you much. However, CBC will give you a clue to the diagnosis. Invariably, the RBCs would be normocytic or macrocytic. Anemia with macrocytic or normocytic MCVs, always it should ring a bell. Number 1. Number 2, presence of 2 cell line affected, thrombocytopenia or anemia, or thrombocytopenia and low count, or thrombocytopenia with very high counts and with hemoglobin not matching, then you should be suspicious. So in such situations, you should always do a peripheral smear. A peripheral smear will give you the clue. If there are blasts in the peripheral, we know that for sure that this is leukemia. A bone marrow aspiration is done to confirm the diagnosis if it is pancytopenia. If the peripheral counts are very high and I have blasts present in the periphery itself, I would not go for a bone marrow aspiration. So the blood can be sent both peripheral blood, if the counts are high and blasts are seen, or in a otherwise pancytopenic, or the counts are normal, but the blasts are say about 25-30%. So if the count is say 4,500 and the blasts are only about 20 to 30%, then I would go for a marrow and do a flow cytometry for acute leukemia panel as such. We will see about it a bit later. So at the same time, send the same sample, take another sample for karyotyping and fish, because all of them help in risk stratification, evaluation, and management of the child. Chest X-ray and ultrasound abdomen should always be done to look at the tumor load as such. A CSF should be done, and first CSF should always be, care should be taken to see that it is not traumatic, because if you make a traumatic one, that means you are introducing CNS infiltration. Okay, so then look for the CSF blast immediately. The blood parameters are to find out the metabolic states, the LFT, RFT, electrolytes, uric acid, calcium, phosphorus. We have already seen that they would all be elevated otherwise. So this is your diagnostic criteria classification. So you have the previously the FAB and the now the WHO is utilized. The cytogenetics, you will see that some of them, when you ask for a cytogenetics, you should be a bit more specific, because if you are looking at acute ALL, then you don't ask for, you ask for an ALL panel cytogenetics, which means you are looking at 422 translocations, 119, or T80 translocation of 814, those kind of things. While with the non-lymphocytic or acute myeloid, again you look for 821 and then 911 and then 11Q 23 22. So these kind of things should be looked for. Now these are all to find out whether they are bad prognostic indicators or good prognostic indicators. So we will see about it a bit later. The chronic ones I will probably not take it. The only thing is that in chronic myeloid we look at T922 isomerism. These are the two things which we look for. So it is most important that once you make a diagnosis of leukemia, you look at the cell morphology. You also look at the cell cytochemistry, the immunohistochemistry, fluorescence microscopy, and flow cytometry. Flow cytometry now plays a very important role. We also need to know the genotype. This is studied with the cytogenetic and molecular techniques, like your polymerase and FISH technique. So when you send sample for flow cytometry, I'm quite sure the pathologists would expect that the blood and bone marrow samples which they receive should not have lysis. So this is very critical for the postgraduates, that they check that it is received, not clotted. So either EDTA or heparin samples can be used. The specimen received should be analyzed within 24 hours. If you are not able to, then please store it at 2 to 20 degrees and do not cause lysis. Very critical. So we run the panel as such. I am quite sure you all know about it. So we look at both cytoplasmic as well as the cell surface markers. And so for B cell, if you want to make a diagnosis of B cell, then we look at 79 and 19. So they would be diffusely positive. For a T cell, it will be CD3 and 7. And within that, you have the different types of classifications as such. And 5 to 20% of all the ALLs can also have myeloid associated antigens. Now this is a bit tricky, because there is a type called as biphenotypic, in which case the biphenotypic cell is a single clone. It is not that there are two mixed clones, and that is called as BLL, mixed. Okay, so this is a single clone, but it produces two markers. One surface marker, which is different, which may indicate a myeloid series, and one cytogenic cytosol marker, which may indicate that it's an ALLC. Okay, so just to put it in short, if you have a mature B cell, then only the surface IgG is positive. For all others, TDT is positive in all the cases of BALL, ALL, and pre-BALL. And CD10 is positive only for pre-BALL. And for you to make a diagnosis of BALL, either of 19, 79, 22 should be possible. So in the cytogenetics, what do we look for? So we look for leukemia-specific translocations. So for ALL, as I told you, it is 1221, 922, MLL, IAMP. Now 922, MLL, they are all bad prognostic indicators. For AML, 821 is a good prognostic indicator. Inversion 16 is a good prognostic indicator. For CML, 922 is generally it has to be positive. This is their BCR ABL. So there are other chronic myeloproliferative neoplasms like polycythemia vera and then progressive myelofibrosis, where we look for JAK2 mutations, CALR and MPL. I don't think you are going to see all these cases in pediatrics, and so we will not rest too much. So once we have seen this, now we look for the risk stratification. So risk stratification consists of the counts, initial counts, the age, and then the response to steroid on day 8, and then day 35 marrow, how it looks, and other conditions. So I won't go deep into this. So this is just to show you that this is a normal marrow. So, and this is the marrow which is hypercellular, and the entire marrow is replaced by blast, low power. And then now look at the blast. So you will see that these are all the blasts. So this is something which I picked up from the book. We don't see this at all. I haven't seen a case of chronic lymphocytic leukemia in my life till date. In chronic myelogenous leukemia, you can see that the precursors are also present. They would also be there. So just to emphasize, I just want to put in 3 case scenarios. 5-year-old girl child presented with fever of 3 days duration. She has been on steroids for the treatment of nephrotic syndrome, and during a follow-up, they found that the child was persistently having anemia and thrombocytopenia, and 2 cell lines affected always go for a bone marrow. So we did a bone marrow, and then we found 50% blast. So it was positive for myeloid series and B lymphoid series. So we are looking at biphenotypic type of AL. This EGIL is a European group of immunological markers for leukemia, and anyway score more than 2 in a particular set. If it is, there should be at least 1, 2 plus with B cell and 1 plus with a T cell for you to make a diagnosis of biphenotype. She was started on ALL induction. Generally, if both are positive, you would look at ALL induction. That itself will take care of it. But if you find that the response is not as good as it is, then we also treat it with the AML therapy. So this is a child. You can see that. You can see the blast, and then you can see the PAS positive. You can also see that it is myeloperoxidase positive. And look at this. CD 45, 10, and 30. So fish cytogenetics, negative for Philadelphia chromosome and MLL translocation. MLL translocation is a very bad prognostic indicator. So here we had positivity for T821. And so the diagnosis was ultimately AML with the T821. It was a biphenotypic leukemia. The case 2 was a 4-year-old female child diagnosed as BALL, received intensive chemotherapy for 4 months. And then at the end of it, they said that they are done with this. Their child looks all right, and so they just simply defaulted. So they came back after 4 months again, and with symptoms, and there was a bone marrow relapse. So we did a repeat bone marrow, flow cytometry and cytogenetics. It was VALL. It was started on intensive chemotherapy, and we said that already it's a case of a relapse, and so you should go for bone marrow transplant once you have achieved clinical remission. So at the time of induction, she also had malignant otitis externa with Pseudomonas, which was treated as such. Now the thing was that when we did a cytogenetics, it was TEL AML and hyperdiploid. Now TEL AML and hyperdiploidy are very good prognostic cytogenetics, and just chemotherapy alone provides them with 70 to 90% cure as such. And so we revised our strategy of asking her to go for a bone marrow transplant. At the end of the induction, we found that her minimal residual disease was less than 0.01. So which means she is responding to therapy. And so she completed successfully her chemotherapy in 2018, and she is doing very well right. So again, just to show you how it helps to do the cytogenetics. Now the case 3 is an infant ALL. Now infant ALL as such has got poor prognosis as such. And look at this child presented with pallor, massive hepatosplenomegaly, and then you have a platelet count of about 10,000, hemoglobin of 7 grams, diagnosed as a leukemia with the high counts, WBC counts. Peripheral smear showed 90% blast. Flow cytometry was CD10 negative bar, and the cytogenetics was positive for MLL translocation. Now, if MLL translocation is present, then we need to counsel the parents that the chances of the child surviving becomes much lesser. So if you look at it, it was ALL with MLL translocation and the very poor survival with a cure rate of 18%. They usually don't do well. They usually die following induction. This child also we lost. So this is your morphological classification along with the WHO classification as such. And basically, I've just put in brief the chemotherapy and the what do you call bone marrow transplant if it is a case of AML if needed as such. So here are the prognostic factors. A B cell precursor less than, as I told you, these are the prognostic factors, and with this we make the risk stratification. We gave you this thing. So when we see clinically cases, sometimes they come only with this, either following therapy or preceding the diagnosis. So many a time we have seen child coming to us with the tumor lysis syndrome. They come with the puffy eyes, decreased urine output, respiratory distress, and then we find that the uric acid, urea, creatinine, electrolytes are all increased, and sometimes they present with malignant hypercalcemia, syndrome of inappropriate secretion of ADH. So we call them as metabolic emergency, and this requires first you will have to first settle this before we even think of treating the child as such. Then sometimes they come to us with hematological malignancies. Now, what do we mean by hematological malignancies? These are quite common. They come with very low counts, WBC counts, and they come with febrile neutropenia, not responding to any antibiotic, very high fevers, and then multiple infections, sometimes fungal, and we need to treat all this before we even think of treating the child as such. The second hematological malignancy is what I was telling you about, hyperleukocytosis, and this would be usually associated with the metabolic emergency. Now, structural emergencies are usually seen with the T cell lymphomas and presence with superior mediastinal syndrome, pleuropericardial effusions, sometimes spinal cord compression. And then, as I told you, therapy related. So therapy related emergencies, we start them on chemotherapy and then they come to us with diarrhea and then extravasation of the chemotherapeutic drug, sometimes causing so much as to cause the entire peeling of structures you will see even up to the bone. Thankfully, we are not seeing that kind of cases now, thanks to the diligent chemo staffs who have been trained on how to give a chemo. And previously, it used to be in small push of the drug in full. Now it is always with 100 ml normal saline, diluted. So that is That is how we have reduced the extravasation part of it. So just to give you a taste of the tumor lysis, 9-year-old male child presented with history of pain abdomen and recurrent vomiting. He was looking emaciated, and the mother was complaining that he had lost suddenly weight about 2 kgs in the last 1 month. Very thin built with a heart rate of 200 and a respiratory rate of 28 per minute. The abdomen had a very doughy feel, and a vague mass was palpable in the umbilical area, measuring about 12 centimeter into 12 centimeter. If somebody comes like this, first possibility we always think of is that probably we are dealing with Burkitt's lymphoma, or it could be that there are other surgical conditions as well. Okay, so it was Burkitt's lymphoma. Now, can any of you comment about the ECG? Any guesses on ECG? What we are seeing? This. So this child had tachycardia, plus you are seeing tall T waves suggestive of a hyperkalemia. So we are possibly looking at tumor lysis syndrome. So ultimately, this child had a surgery, and look at the mass. His sodium was normal, potassium was 6.5, uric acid very high, 11, calcium was low, phosphorus high, and urea creatinine for that particular age was on the upward swing as such. Uric. So this was a diagnosis, TLS or tumor lysis syndrome. So tumor lysis syndrome is a metabolic derangement secondary to rapid tumor cell breakdown. So this can either be because of the drug, or it can be spontaneous because the tumor actually grows much faster than its nutritional supply as such. So it is characterized by hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, and with abnormal renal functions or azotemia as such. So it is a life-threatening oncological emergency, and this has to be managed first. Treatment consists of providing hyperhydration with the Lasix, at the same time monitoring that he doesn't go into congestive cardiac failure, because they usually have anemia also. So these are the other life-threatening complications as such: neutropenia, overwhelming infections, and then thrombocytopenia can produce bleeds, electrolyte imbalance we have already seen. So reticular endothelial system infiltration is where you have the mediastinal mass and all that. This we have already discussed. So again, just to put it, these are all favorable and unfavorable prognostics. And what do we mean by minimal residual disease? Usually done on the day 35. We look at the bone marrow and look at the immunophenotype. We know the type, and so flow cytometry helps in identifying the one leukemic cell among the 1 into 10 to the power 6 normal cells. So our target is that it should be less than 0.01. So if it is 0.01%, that means the child has achieved a remission, and that should be at 35 days. That is a good prognostic sign. In a T cell, we don't do the bone marrow at the end of 35 days, or MRD at the end of 35 days. We do it at the end of 70 to 75 days. This is at the end of consolidation. With the AML, the MRD is target is 0.1 and not 0.01, and this is again done at the end of induction 2 as such. So these are all the supportive care that may be required. So I'm not going into all this. So within AML, we divide them into only two types: AML M3 and non-M3. Why AML M3 is because AML M3 has got a very high cure rate of 87%, single drug therapy. If you can give ATRA, we call it as all-trans retinoic acid, In adults, they use ATO also, that is arsenic trioxide. But if you can use ATRA along with one single drug, the treatment is complete. While for all the other non-M3, we may have to go for a standard chemotherapy. If they have good cytogenetics, then we have a high threshold for bone marrow. But if they have bad cytogenetics or normal cytogenetics, then we should have a low threshold for advocating bone marrow transplant. Probably coming to the end of the program, lymphomas, just a small this thing, comprises about 15%, consists of two types, Hodgkin's and the non-Hodgkin's. Hodgkin's, for you to make a diagnosis, you have to show me one Reed-Sternberg cell at least. If you don't show me a Reed-Sternberg cell, then I will not accept it as Hodgkin's as such. We put it as non-Hodgkin's lymphoma. Among the non-Hodgkin's lymphoma, we classify them as Burkitt's, lymphoblastic lymphomas, and then DLBCL, the diffuse large B-cell lymphoma, and the anaplastic large cell lymphomas. So pediatric NHLs are usually very high grade. The good thing is that they respond very well to chemotherapy. Most of them present with oncological emergencies only, and the overall cure rate is around 70%. So this is in brief about the Hodgkin's and the non-Hodgkin's as such. The slides would probably be with you. I can share it, then you can always look at it. So as usual, we do the staging. So staging is up to 4. And the prognosis and cure rate for Hodgkin's is more than 90% up to stage 2A. And for stage 2B, 3A, and 4, it is still not bad. It is 80%. While for stage 1 and 2 with the lymphoblastic, it is 80%, 90% for Burkitt's, and 90% for large cell. For stage 3 and 4, it reduces a bit, 60 to 80% for Burkitt's, 60 to 80% for large cell. And the treatment consists of providing chemotherapy plus or minus radiation, which is decided at the end of the response to chemotherapy. So if time permits, we can have the questions.
Forum is open for discussion. If anyone have query, they can ask. They can unmute themselves and they can ask.
Sir, thank you very much for the vivid presentation, sir. And you reminded us about how much we have to really correlate with the clinical presentation, and the follow-up is very important. Thank you so much for bringing out those essential aspects of the clinico-pathological correlation. I would ask you one thing, sir. Like you were talking about the tumor lysis syndrome. In your experience, how many of them go in for tumor lysis syndrome? How frequent it is, and how do they come out?
From my experience, we get at least 20% of them with tumor lysis syndrome. And the important thing is that we have to first identify it, and remember that the tumor load is very high. Prevention is always the best. So the moment the child comes to us and we make a clinical diagnosis of a tumor, and then we put them on allopurinol. Allopurinol helps in preventing the conversion to uric acid, and it is excreted in the urine as not a uric acid but a pre-uric acid metabolism. That is the advantage. Then hyperhydration. So first 3 or 4 days we don't start on chemotherapy till we find out that the uric acid levels are normal. But sometimes they come to you directly with uric acid very high. The last case we had a uric acid levels of about 20, and that was the one who presented with the count of more than 2 lakh. So the moment you have a very high count, keep tumor lysis in mind. You don't have to even start on steroids. The moment you start on steroids, the tumor lysis worsens. But here what had happened was his initial presentation itself was that he had a mild puffiness, decreased urine output. So we clinically suspected him to have tumor lysis, and we found that the counts were very high. If you have very high counts, that means there is leukostasis. So it will be very difficult to give him a blood, because you are only giving PRBCs. So you will increase the viscosity, will probably precipitate a stroke. So it is what you call walking on the knife edge. he presents with the congestive cardiac failure, maybe we also put him on IV fluids, hyperhydration with the Lasix at 0.04 milligram per kg per hour. It is not a push. And then we also give him small transfusions. And if it is a must that he has to have a chemotherapy. For example, he also might present with the mediastinal mass, which is big, and so he's having a stridor. So that case, you need to give the drug. Otherwise, he will die of obstruction. So in that case, we start with a very low dose chemotherapy. DEXA is usually started, and we start at the usual requirement is 10 milligram per meter square. So instead, we start with the 4 milligram per meter square for 2 days, continuing hyperhydration. Rasburicase is one drug which would help in bringing down the uric acid extremely fast. So put him on allopurinol plus injection rasburicase, and then hope that he comes out of it. But it is only a question of hyperhydrating him with enough fluids, at the same time not precipitating a congestive cardiac failure. So he will have to be in ICU for management. And the parameters are not monitored once in a day. They have to be monitored every 6 hourly as such. So the child whom we have got Burkitt's lymphoma, whom we had shown, that fellow is right now alive, but he's not responding to the therapy. But when he came to the ER, he came with the tachycardia, and when we put him on the monitor, we found tall T waves. We started treating him for the hyperkalemia straight away. Meanwhile, we were waiting for the serum. Now the point is that when you squeeze and take a blood, or when you take the blood with the not a wide bore needle, then you will have sample lysis. So you will have high potassium values in that also. So an ECG monitor will also tell you that there are no tall T waves, but your potassium values may be 7, the child may be comfortable. So you need to look at all the parameters together. We get about 15 to 20% of our cases with tumor lysis.
Okay.
But we prevent them by, first thing is hyperhydration for the first, and the fluid requirement is 3 liters per meter square. So roughly it works out like this. Less than 10 kgs, 1 liter. Between 10 to 20 kgs, it is about 2 liters. And beyond 20 kgs, we tell them that they have to take 3 liters of fluid per day. Orally preferable instead of giving IV. The IV is given only if the child is not able to tolerate oral or is sick, too sick to take oral. Yeah.
Okay, sir. Thank you.
Thank you.
Sir, excellent presentation, sir. Thank you very much. Sir, what about the incidence? What type of leukemia goes in for tumor lysis syndrome, sir?
The T cell types, ETP, T cell lymphomas usually go for tumor lysis, and the early T cell precursor tumors, they usually present with mediastinal mass, and if you look at the tumor load, it is quite heavy. Clinically, we always suspect that this child will go for a tumor lysis if you see a large spleen, large liver, high counts, and huge nodes. Nodes could be anywhere, whether peripheral or in the central, meaning the mediastinum, the mesenteric nodes. Burkitt lymphoma melts actually. So that also goes for tumor lysis. So if the tumor load is very high, then they are most likely to go in for tumor lysis.
Sir, I have one question.
Yeah.
What is the incidence of ALL in a higher age group, sir? Around 30s. Do you see any ALL?
They're not as common as they are in children, but I have never seen an adult in my life. So I wouldn't be able to tell you exactly the incidence, but from what I see in the textbooks, CMLs and CLLs are quite common there, while ALL and AML are very common in the.
What is the highest age group you have seen, sir?
Up to
ALL.
19. We treat up to 19. Sometimes I do take even the ones who have been on with us on treatment from 17 years onwards. I don't tell them that you go off. So we do treat them up to 19 years. We do take care.
Yes, sir. Thank you so much.
Any other queries from the other participants, please?
Have they put it in a chat or something?
Sir, they have actually appreciated the talk, sir.
Oh. No, you can also put it in the chat so that I can also look at it and then answer. Absolutely no issue. Have I exceeded the time? I'm sorry if I had exceeded the time.
You are well.
No, you are well within it.
Start with diagnosing, and if at all they are giving the therapy, post therapy follow up, they used to send for the samples. Only we are restricted to that part alone. But these emergencies actually we are not handling like this to see the patient actually and correlate. So it was really a what to say, like it is telling us what we have to do. So that way it's an eye opener, sir. Thank you.
What happens is the postgraduates, when they send a requisition, they don't put a diagnosis. They just put the patient's name, age, and then they just send it as CBC peripheral smear or only CBC.
Correct.
And when the counts come high, they just simply write it as the name, age, and peripheral smear. Now, it is very important that you also actually give a small gist of what the child is suffering from. Now, I will tell you a classical example. What I do is, as soon as I finish my OP, I always go to the pathology people and then we discuss the bone marrow and the previous bone marrow, or I tell them that you have given me this diagnosis, I'm not convinced. To me, it doesn't look like that. And I also tell them that this is what I am suspecting, so that they will look more carefully. So we had this case, a case where there was a mediastinal mass. The child presented with only a mediastinal mass, otherwise nothing. In fact, all his bone marrow results and all were negative. The only thing was that he had a history of having been sick for more than 2 months. And in that 1 month, he was in a private sector hospital where they had done all the investigations. Bone marrow was normal. And then they referred him to us. My only clue was that he had a mediastinum which was widened. And so his counts were what you call borderline. It is easy to make a diagnosis if you have a low count, say platelet 20,000, anemia 5 grams, and neutropenia, or let us say a total count, leukocyte count of say about 1,500. We will obviously go for a bone marrow directly. But what would you do if the platelet is 1.45 lakh and the hemoglobin is around 11 and the WBC count is somewhere around 3,600? So this is how he presented. And then we didn't have a clue. He did a bone marrow. And when he did a bone marrow, I told them that I've seen a mediastinal widening. I'm doing this bone marrow knowing fully well that it is not warranted by the counts. I'm still doing it because I suspect him to have a leukemia with the weight loss and the fever and all that. It turned out that he had ALC. Bone marrow was normal. And then they said no marrow involvement, nothing, the child is still normal. The parents were persistent saying that he has lost weight, he is complaining of bone pain and all, and he's not doing well generally. So I said, let us go for a mediastinal node biopsy. So a mediastinal node biopsy was done, and it turned out to be ALCL. So it requires that high index of suspicion, and we need to keep on talking with the pathologist. And otherwise, what happens is the pathologist would just look at the smear and he doesn't know the history. So there was this the classical finding. They had referred it to me as a case of leukemia, a 4-month-old child with a very high count, about 70, 80,000. 80,000 counts, 4-month-old with the hemoglobin of 4 grams and a platelet count of 2.3 lakh. Now 4 months, and then I simply asked them where are they coming from, and she said that I'm coming from Jamuna Marutur. Jamuna Marutur is in the Vellore district as such. That was the history, and then they said that uric acid is 12, and then calcium is 5, and all that. I told them potassium is very high, 7, sir. This is tumor lysis syndrome. Child is edematous, and it looks like leukemia. So, shall we proceed with allopurinol? I had a look at the child. He had a hepatosplenomegaly, and what they said was true that it had edema and all. But this high platelet count, and they didn't see the smear. And a count of about 75,000 with hemoglobin low coming from Jamuna. I put it as acute hemolytic crisis, do the bilirubin levels and LDH, and I want to see the smear. And the diagnosis they had put was ALL and sent it to the pathology. And pathology, they had said that we were able to see precursor cells. A few precursor cells were seen, and AML was a possibility. So then I told them, to me, the area they come from is suggestive of a hemolytic anemia. And so I would look at hemolytic crisis. Can you please do the smear properly? I will give you the head smear and let us look at it again. So the 75,000 that you get in a CBC is because of the false high counts of nucleated RBCs being counted as leukocytes. So once we saw the smear, once we saw plenty of target cells, and once we saw the fragmented RBCs, polychromatic cells, nucleated RBCs, I said this looks like a case of the child was not 4 months, sorry, it was about 8 months. I told them, do an HPLC, you will get a TAL. So high fetal hemoglobin F, and it was a diagnosis of TAL major. Both the parents are subjected to HPLC, and they were trained. So it is a must that a clinician should actually write a small brief about the case and discuss it if he doesn't agree with them, because the pathologist sees only the sample, he doesn't see the case. So maybe you would be a better clinician if you see the case also, because you see the case plus you see the smear.
It's true, sir. Actually, we come across this difficulty very frequently. So we'll be seeing only one part of it, and even if we try to get the history from the clinicians, like we get only the half history. So
Similarly, when we run the flow cytometry, I do discuss with them. I tell them that to me it looks like a T cell, and so I want T cell markers also to be put. So those kind of things can also be discussed. Otherwise, the single cell lineage is put. When we make a diagnosis of BALL, then when you put a ALL panel, and this biphenotypic was something which came that time. So we were breaking our heads to find out why this fellow was not responding. And then we found that he had a biphenotypic ALL. So things do occur. You may not be able to go daily and discuss with the pathologist. I make it a point to discuss with them daily. But at least for those cases where there is what you call a conflict of diagnosis, or you are not very sure, then I think there is no harm in just picking up a phone or coming directly, have a cup of tea and discuss it, and then just go ahead. It's always there.
thank you, sir. Thank you so much. Thank you.
Thank you, ma'am. So I don't see any questions.
No, sir. I think your presentation was really very nice. So it was very clear. They didn't have any queries.
Yeah. Usually, when no questions arise, there are only two things. One is it was too good. The other one was that nothing went into their brains.
No, sir. It was
No,
very.
sir. It was really good. Very
Thank
nice
you.
presentation.
Thank you. So should we quit?
Sir, the next presentation is there now. So
Thank you so much, sir.
I think I'll leave then. Thank you. Thanks a lot for having invited me again.
Thank you, sir.
shall we move on to the next presentation, Dr. Dharmeshna, please?
Good morning, one and all. Am
I'm Dr. Anand, Faculty of Pathology Department in CRA. It is indeed our privilege to introduce our next speaker, Dr. Mary Teresa Manipada, Madam. Currently, Madam is officially in the post of Professor of Pathology in CMC Vellore. Madam has completed MBBS in Mahatma Gandhi University, Kerala, and she has completed MD Pathology in the renowned Calicut University. She has also completed DAB in Pathology in National Board of Examination. Madam has started her career as a consultant pathologist at Amala Cancer Hospital, Thrissur, Kerala. Later, she joined CMC in the year 2007 and working as a professor of pathology till date. Madam has been assigned as a course coordinator for Hematology Fellowship course, and Madam has been honored with gold medal by Dr. Moli Peno Memorial Award Ceremony for Best Teacher in CMC Vellore to date 2009. Madam currently responsible as a lead pathologist in the Department of Bone Marrow Refined Biopsy, Lymph Node Section, Breast and Endocrine Specialties. Madam is an executive member of IAPM Association, and she has been invited faculty and speaker for many seminars and academic forums across the world. With regard to publication, Madam owns 78 peer-reviewed publications, and she has had a chapter in one book. She has published many papers and posters in conferences, and she has supervised many research projects as well. And she is the quality control auditor in histopathology and hematology section in various specialties in CMC Vellore. She is the task force member in drafting curriculum for competencies for UG and PG curriculum. She has been examiner for MD pathology and PG courses, postdoctoral fellowship courses, and DC member for PhD candidates. Madam is a winner of All India Quiz on Online Quiz Competition in National Conference of IAPM held at PJ Chandigarh in 2007 and also in Chennai in 2008 consecutively. Madam, we are all eagerly waiting for academic feast in topic approach to introductory qualification of breast. The forum is all yours. Thank you.
Can you hear me now?
Yes, madam.
Yeah. And you can see my screen?
Yes, ma'am. We are able.
Okay. Thank you so much for inviting me. Thank you to the organizers, including Dr. Soumya. And thank you for that introduction. Although I am not the quality manager of the department, though I have been involved in quality control activities. So today's topic is an approach to the diagnosis of intraductal proliferations of breast. So intraductal, can you see my screen now? Is it moved?
Yes, ma'am, it is.
Okay. So when we say intraductal proliferation, today we are discussing intraductal proliferations which are confined to the mammary duct lobular system, and most of them arise within the terminal duct lobular unit, which is what you see here. So that's what we discussed today. There is a group of proliferations which occur in the larger duct in the breast, which is intraductal papilloma, etc. But most of the common proliferations arise from this terminal duct lobular unit. So the major categories under these are usual ductal hyperplasia, atypical ductal hyperplasia, ductal carcinoma in situ, and columnar cell lesions. So these are the four main things we will discuss today. Now, what's the clinical significance? All of them have a slight increase in breast cancer, but of different magnitudes. So you can see that in the next slide. Usual ductal hyperplasia is a slight risk, a very slight risk. It's just 1.5 to 2 times the normal population. But you can see here, it's in either breast. It just shows there is breasts have a tendency for proliferation. It's only a generalized risk and only up to 1.5 to 2 times. And there's nothing to be done for its management. It can be left alone. Now, when you talk about atypical ductal hyperplasia, the risk is slightly more, and either breast can be affected, but it's more common in the ipsilateral. Wherever you found the ADH, there is a slightly higher risk in that breast to get a carcinoma. The treatment is, if it has been excised already, then you just have to do active surveillance, sometimes chemoprevention. But if it's on the needle biopsy, you diagnose it, you have to do an excision. For low-grade DCIS, the risk is much higher. It's only in the same breast, and it requires complete local eradication and complete excision with margins. In flat epithelial atypia, which is also a proliferative intraductal lesion, the risk is much lower than that of ADH. The ADH was 3 to 5 times. This is around 2 to 3 times, and there's nothing much that's required. You just have to follow up and see whether the radiology, is there anything worse on radiology? So you can see here that the magnitude for breast cancer varies widely among these lesions, and therefore, and the management also differs. In UDH, you don't have to do anything. ADH, you have to excise. Low-grade DCIs, you have to have a complete excision with margins. And the flat epithelial atypia, you need to do radiopathological correlation. If there's anything worse on the radiology, you'll have to excise that. So we will see today how we'll differentiate between these. So for a pretest, this is case 1. What do people think of this? You can add it in the chat box.
Someone says UDH, madam.
UDH. Any other
UDH.
only UDH?
Two of them have replied ADH, ma'am.
ADH. Okay. So let's go on to the next case. You can put the answer in the chat box. What do you think this is?
ADH. Majority of them have replied ADH.
ADH. So now I will discuss this, and later we'll discuss what this happens to be. So in today's talk, I will cover usual ductal hyperplasia versus low-grade DCIs, usual ductal hyperplasia versus intermediate-grade DCIs, low-grade DCIs versus ADH, and diagnosing columnar cell lesions and flat epithelial atypia. So first, usual ductal hyperplasia versus low-grade DCIs. Now, could the postgraduates put in the chat box, what's the main difference between hyperplasia and neoplasia anywhere in the body? What is the main difference between something hyperplasia and neoplasia? If you can just put it in one line or one word.
Atypia, nuclear features.
Okay, that's how you differentiate it. But what I'm asking is, what's the main basic difference?
Small proliferation.
Yeah. Neoplasia is, so that's correct. Neoplasia is a clonal proliferation. That means it's a cell committed to one line of differentiation. It's only one type of cell. That's neoplasia. Hyperplasia, it's an increase in number of cells, but it is not clonal. So that's the main difference we have to remember. DCIS is a neoplastic or clonal proliferation of malignant gland-forming cells. Those cells are committed to luminal differentiation. Whereas UDH, usual ductal hyperplasia, is a proliferation of uncommitted pluripotent epithelial cells, which means all the cells in DCIS are committed to luminal differentiation, or they are luminal cells, whereas UDH starts from a pluripotent cell which is uncommitted, so it can go differentiate along epithelial as well as myoepithelial pathway. So let's look at UDH. Normally, you know, the TDLU is lined by two cells, two layers, one luminal and one abluminal or basal or myoepithelial. Now, if you have 3 or more cell layers above base membrane, you can call it UDH. It can be seen at all ages, and
She has that day also it was there. I request all of you to stay patient. So there is some connectivity problem from the speaker side. So ma'am will reconnect again. Till then, please stay patient.
Can you hear me now?
Yes.
Yeah? Yeah, okay. Sorry for that. So usual ductal hyperplasia is seen at all ages, and if it's isolated, it does not give rise to a clinical or radiologic lesion. If it's in association with other lesions like fibrocystic disease or sclerosing adenosis or anything like that, then you get a mass or something on the radiology. If it's on its own, it does not show any clinical or radiological sign, but it can be seen in isolation as well. So, as we said, it's a proliferation of primitive pluripotent stem cells. But as I said, it is capable of differentiating towards epithelial and myoepithelial, but actually, it does not realize the full potential into either. It does not become fully luminal or fully myoepithelial, but it proliferates without too much of differentiation towards anything. It's an uncommitted cell. So what characterizes this proliferation is that they are benign cells, so they are markedly cohesive. And there is no polarization, which means they do not form, the cells which form glandular lumina usually polarize. And when we say polarize, it means two things. One, it is oriented towards the lumina, and it has a basal compartment which contains the nucleus, and an apical compartment which is towards the lumen. So either usual ductal hyperplasia, there is no polarization because these cells are not committed to glandular formation. And there's marked cohesion because it is a benign proliferation. And there's lack of cytologic atypia. So what do we see? See that this is a lumen which is completely occluded by proliferating cells. What do you see here? These are cells which are actually touching each other. They're almost very cohesive proliferation of cells. There is no polarization or luminal differentiation. So when you see this, there are some few slit-like spaces in between, but there are that you can't clearly see any polarization or glandular formation. So you would think of usual ductal hyperplasia. Sometimes, like here, you've got this proliferation of UDH starts at different points along the perimeter of the duct. And then in the center, they form a big mass. So when you get a central mass of cells, which is supported by these thin strands of cells, it's a very good clue that this is a benign lesion. There's see these thin strands because they taper towards the center. Okay, and look at these cells are very close to each other. They're very irregularly arranged because and they're very close to each other because they are cohesive cells. They overlap with each other. And you've got these slit-like spaces or irregular spaces all around it, which is the original lumen of the duct. Can you see that? These are irregular spaces. So this was the first case we saw. This is a usual ductal hyperplasia. Because of the cohesiveness, they overlap with each other. Because there is no polarization, you cannot see any well-formed glandular structure. The cells are sort of just arranged in masses. And when you see these thin strands, that's because these cells are compressed, and they can be compressed by the adjoining cells because they are so cohesive. See that? Irregular fenestration. So when you see this, it's very characteristic of usual ductal hyperplasia. The other one other feature we see here is called streaming. Streaming also happens because the cells are so cohesive. You can see the cells in the center flattening out each other, and they form like a parallel arrangement of cells, of nuclei. So this is called streaming. And when it occurs in the center of a mass, it may even look like swirling. It's all the same thing. It's because of marked cohesion of the cells. They're benign cells. And these are these thin strands where the nuclei is so compressed and they're flattened and they're directed along the along the direction of the strand, of the cellular strand. So when you see all this, you would think of a usual ductal hyperplasia. Another feature which you see here is maturation. This is not seen in every case of UDH, but in some cases you can see that, and that is that the cells at the periphery of the duct will be more larger and active and proliferating. And in the center, you have very condensed nuclei and very eosinophilic, much more eosinophilic than the periphery cytoplasm. The cytoplasm appears more eosinophilic. So this is called maturation. If you see this with a condensed nuclei and very pink eosinophilic cytoplasm, you would think of UDH. So these are the features of usual ductal hyperplasia. Same thing again. So there's streaming of cells. The cells are all very cohesive, touching each other. There's no particular arrangement. It's just a mass of cells. And you will get streaming of cells, swirling, and irregular fenestrations. And when you have these struts or strands, that's those cells which we saw in, I'll just go back there. When you see these struts or strands which support the central mass, they're all very thin and delicate, and the nuclei are arranged along the direction of the proliferation. So these are features of a benign proliferation, and the reason why they all look like this is because of the cohesion and by the lack of polarity. And as we've already seen, cell membranes are not seen because they're all very cohesive and actually compressing each other. There's an irregular distribution, there's clustering, there's overlap, there's reniform or folded or convoluted nuclei. Granular chromatin may be seen. Then you may see a small nucleolus. And then one feature we see in, so all this is what I already said for usual ductal hyperplasia. One feature which we sometimes see is something called a helioid body. That's an intranuclear cytoplasmic inclusion, which you can see in UDH. You can see sometimes in irradiated breast and in high-grade carcinomas, but otherwise, it's generally a feature of benignity. So what you rarely see in UDH is calcification is hardly ever seen, necrosis is hardly ever seen, and mucin. So if you see all this, you have to be a little more careful deciding whether it is UDH. Now, one question is, does UDH progress to ADH or DCIS? We said all of them are proliferative lesion. Can usual ductal hyperplasia, if you see that in a patient, do you have to worry whether this will become atypical ductal hyperplasia or DCIS? Actually, UDH is a biologic dead end. Low-grade DCIS does not arise from a UDH. So UDH only confers, as we saw in the first table, only confers generalized risk of increased malignancy, but only a very small risk, 1.5 times the general population. So if you see usual ductal hyperplasia, it can be left alone. It will not become low-grade DCIS or atypical ductal hyperplasia. That's a completely different pathway. Now we come on to the more sinister proliferative lesion, that is ductal carcinoma in situ. And there's a group, it is a heterogeneous group of diseases. Low-grade ductal carcinoma in situ and high-grade ductal carcinoma in situ have completely different molecular profiles. So they're not the same disease. Anyway, so it's a heterogeneous group of diseases. And whenever there is screening mammography is done, ductal carcinoma in situ becomes a 1/4 at least of the screen-detected cancers. Where there's no screening, we often see invasive stage of the disease. So what do you pick up on screening? You see rod-shaped and branching calcification or granular calcification. This also only rarely presents as a mass, or Paget's disease or nipple discharge. And when it presents as a, if you see it as a mass, the patient can pick it up, or if you can see it on the gross examination, it's mainly because there's marked periductal inflammation, which forms the mass, or periductal fibrosis. And sometimes you can see it on gross as the typical necrotic debris coming out as a paste, as like a paste out of the dilated ducts. So that is often seen when there is comedonecrosis. So these are the gross morphologic features of DCIS. Now, the main points to differentiate UDH is from low-grade DCIS and intermediate-grade DCIS. It's not from high-grade DCIS, which is a very markedly pleomorphic proliferation, and nobody has a doubt about that. So now we'll see how will we differentiate a low-grade DCIS from usual ductal hyperplasia. Now, low-grade DCIS, as we said, is a clonal proliferation, and they are all luminal cells. So they differentiate towards luminal cells, and they are very polarized. As I said, there's a nucleus at the periphery and the apical compartment as cytoplasm, and there is a discohesion. So there's not the marked intercellular cohesion, which we saw in the UDH, is not seen here. So these are the 2 points you to remember. It's clonal, it's luminal, clonal towards luminal differentiation, it's polarized, and there is lack of intercellular cohesion. So what happens when there's lack of intercellular cohesion? What happens when there is luminal differentiation? Luminal differentiation will result in cribriform spaces and the variance of cribriform spaces. Look at this. This is a usual ductal hyperplasia, this is a DCIS wherever you see it. All the cells are luminal cells. They all polarized around lumina. So this is a cribriform architecture. So you can see this is a very well-formed polarization in cribriform architecture. So there's no doubt, but this is a good picture to see that all the nucleus is towards away from the lumen, and you have an apical cytoplasmic compartment. They're all arranged perpendicular to the lumen. So they're like spokes of a wheel. Here again, you can see it. It's not as well developed as there, but you can see that here. So this is a ductal carcinoma in situ, and that's mainly because the cells are polarized. And what else do you see? We said lack of cohesion. You can see that here. The cells are separate from each other. Can you see that? It's not like in the UDH where everything was touching each other. Here you can see the nuclei which is separate from each other with well-defined cell membranes. Most of the low-grade DCIs, we are talking only about low-grade here. Most of the low-grade DCIs has well-defined cell membranes, and you can see the cells separate this because of the lack of cohesion. So now I said about polarization. Now, normally, the cells which are next to a basement membrane will polarize. When you see polarization away from the base membrane, you will start thinking of DCIs. Okay. Now, what are the variations of cribriform spaces? These are called, this is not a very good one, but a Roman bridge, they call it. That means you've got an arch-like thing around the periphery, and the cells are arranged perpendicular to that bridge. Here you can see that. So when you see this cells arranged perpendicular to the lumina, you will start thinking, okay, this is an atypical proliferation. This is a clonal proliferation which is committed towards the luminal differentiation. And when you see bridges like this, the nuclei will be perpendicular to the long axis, as opposed to the UDH where we saw things which are parallel to the long axis. So here again, you can see the polarization, and you can also see that even though there's some overlapping, in most of the areas you can see that the cells are separate from each other. That's because of the lack of cohesion which occurs as a part of the neoplastic process. This regular placement of cells. See that discohesion, a little bit of discohesion. It's not like it's completely separate from each other, but they do not compress each other. That's why you get a regular placement of cell. You see well-defined cell borders. So then you will think of a low-grade DCI. So see that beautifully seen here. Now, what are the nuclear and cytoplasmic features of a low-grade DCIS? can see the nucleus has got a fine chromatin. It's a dispersed chromatin. This is all low-grade DCIs I'm talking about, dispersed chromatin. And the cytoplasm is, again, granular, eosinophilic, and quite abundant. In all this is in low-grade DCIs. And there is a significant amount of uniformity because it's a clonal proliferation, and it's differentiated because it's low grade, it's differentiated. So you've got this clonal proliferation. So same thing, uniform population, round tubal nuclei with smooth contours, consistency of chromatin texture, which is finely dispersed. And when you get prominent granularity of chromatin, you would start thinking of an intermediate grade DCIs. This is what we discussed. Same thing, so this is a low grade DCIs. So in this picture, this one is the low grade DCIs and this one is the ADH. We'll talk about this a little later. This is the UDH, usual ductal hyperplasia, where you can see fenestrations or irregular spaces, and here you can see these punched out spaces. So if you have a doubt, sometimes there are cases which we have doubts, then two markers which will help you to differentiate between usual ductal hyperplasia and low-grade DCIs is cytokeratin fiber 6 and estrogen receptor. Cytokeratin fiber 6 is a basal marker. So basal cells or myoepithelial cells will stain for CK fiber 6. So I said in usual ductal hyperplasia, there's a differentiation towards both ends, both luminal and myoepithelial. So some of them are staining very highly for CK fiber 6 and some are completely negative. This pattern is called the mosaic pattern in usual ductal hyperplasia. Suppose it was a DCIS, you wouldn't find this at all. In a low-grade DCIS, you will not find any CK fiber 6 in the center. Only the basal cells at the periphery will stain because it's a clonal proliferation which differentiate towards luminal cells. So this is a higher power. So you can see many cells which are negative. So this one single stain often helps us in case there is a difficulty between UDH and a low grade or an intermediate grade DCIS. And in DCIS, as I said, there will be no cytokeratin fiber 6 within the proliferating cells. Only the basal cells will stain at the periphery. And there will be a uniform expression of ER and PR because all of them are luminal. All of them will express ER. And these are, I'm talking about low-grade DCIs. Whereas in a usual ductal hyperplasia, there's some are epithelial and some are myoepithelial. So ER will show different types of staining and many will not stain. This is a low-grade DCIS with a uniform ER stain. So usually in our practice, we use CK fiber 6 if there is a doubt. Most of the cases from morphology itself you can make out. ER is hardly ever used. This is P63, which is the myoepithelial cell which stains around the DCIS, which shows that it's not invasive and it is within the duct. There are patterns in DCIs. There's comedo, cribriform, solid, micropapillary. This is comedo with central necrosis. This is clinging pattern where you just see one row of cells. Some people say there is low grade and high grade clinging, but whatever, usually we see the high grade. This is the cribriform pattern. So this is one of the pre-test slides I showed you. It's very clear. You can see polarization and luminal differentiation away from the base membrane. This is a particular kind of DCI, which is called the micropapillary DCIs, where you can see markedly dilated glands with dilated ducts with papillary projections into the lumen. And these papillary projections do not have a fibrovascular core. And there are some points to differentiate it from micropapillary hyperplasia, but I'll discuss that in a while. So this is all micropapillary DCIs. This is on higher power. Now, intermediate grade DCIs has it's a little bit difficult to differentiate from UDH in that it does not polarize because they are losing their differentiation. They're becoming higher grade. So you may not find polarization everywhere. You have to look for it. Often it's solid sheets. You can see that. But things which will help you is that the hyperchromasia, the enlargement of nuclei and nucleoli, and irregularity of nuclear membrane. These cells will be much larger than the usual ductal hyperplasia. And the polarity may not be obvious all the time. It may be there focally. So often the difficulty comes in intermediate grade DCIs versus usual ductal hyperplasia. Low grade DCIs is not difficult because the morphology is very characteristic. So this is an intermediate grade DCIs. It's little more crowded than before, but you can see that the nuclei are larger with more granular chromatin. And if you do it, this was an ER, and that's strongly positive. So distinguishing features between intermediate grade DCIs and usual ductal hyperplasia is that the size is larger, pleomorphism is more, and the chromatin is more clumped and granular. Now, high grade DCIs, there's no doubt about it. These are very pleomorphic cells. Even if you look at it, you know it's a cancer. So that actually is not a difficulty in diagnosing. So grading, there are different methods of grading. This is one that's used in the UK. So they go by the size of the cell nuclei. In high grades, more than 2.5 times the RBC, and low grade is below 1.5 times. Pleomorphism is graded. The nucleoli. Polarization is absent in high grade. So that you should remember when we talk about polarization away from the base membrane, that helps only in a low grade proliferation. In a high grade, it's absent, but then the pleomorphism is so much that you won't have a doubt. Mitosis is frequent, necrosis may be present, etc. This I've discussed. What is atypical ductal hyperplasia? Now, atypical ductal hyperplasia has features very similar to low-grade DCIs. Whatever we said, monomorphic cells, well-defined borders, evenly spaced round nuclei, bridges, arcades, all that. But it should occupy less than 2 duct spaces or less than 2 millimeter. So basically you're seeing a low-grade DCIs in a biopsy, but it's just in one space, or it's only 1.5 space. The whole duct is not involved, and it's less than 2 millimeter. Then you can call it atypical ductal hyperplasia. If you get a high-grade DCIs, whether it's half a duct or full duct, or more than 1 or 2 or whatever it is called, ductal carcinoma in situ. So ADH is a low-grade proliferation. So there are 3 things in ADH. There's an architectural pattern, which is like low-grade DCIs. There's cytology, which is like low-grade DCIs. And there is extent. The extent should be less than 2 ducts, 2 full ducts, or 2 millimeter. So here you can see, this is a single duct. So if it's confined to the 1 duct or 2 ducts, less than 2 ducts, you can call it. But it looks exactly like a low-grade DCIs. So in this duct, there is a bit of low-grade DCIs, but half of it is not involved. So then they would call it ADH. It's less than a duct, or it's only half a duct. So what do you do with an ADH? If you get it on a core biopsy, you have to do a wide local excision. And if you get it on an excision, they say that regular mammographic follow-up is sufficient, because the risk is only 3 to 5 times, because the extent is very small, it's very less. Remember, it's only in a low-grade DCIs like area. If you get a high-grade DCIs, if it's even very focal, very small, it's still called a DCIS high-grade, not an atypical ductal hyperplasia. Now we'll rush through the columnar cell lesions. What do you see in columnar cell lesions? You get an enlarged terminal duct lobular unit, and it's lined by columnar cells. See that? So when you look at on the low power, you often see a very blue-looking and slightly dilated lobule. Then you will think, is it columnar cell? You go on to high power, you'll see these columnar cells, nuclei, with elongated nuclei, and this apical snouts. So this is columnar cell change. This is columnar cell hyperplasia, which means there are more than 2 layers of cells, and they're sort of impinging on each other and projecting into the lumen. So this is columnar cell hyperplasia. This also has no risk of cancer. This is something called flat epithelial atypia. When you get a columnar cell proliferation, you've got these apical snouts, you've got dilated TDLU, but the nuclei are not columnar anymore. They're not elongated. They're becoming rounded and they're becoming slightly atypical, low-grade atypia, but still the epithelium is still flat. There is no complexity, or there's no bridges, or there is no trabecular bars, nothing. So then you would call it flat epithelial atypia. So these are the three lesions under columnar cell change. Columnar cell change, which means 2 layers of tall cells with apical snouting and elongated nuclei. Columnar cell hyperplasia, same thing, more than 2 layers. And flat epithelial atypia, your nuclei have become rounded with little bit of chromatin clumping or granular chromatin. So, and you still got the apical snouts. It's a low-grade atypia in a columnar cell lesion. And flat refers to the lack of complex architecture. The cells are still columnar, but there is no complexity, so it's called flat. So you should remember that CK fiber 6 is absent. The CK fiber 6 we use to differentiate usual ductal hyperplasia from DCIS is absent in columnar cell lesions, so that cannot be used as a marker for atypia. But they're diffusely and intensely positive for ER and PR. Now, molecular studies have shown that flat epithelial atypia is a clonal lesion, and it has some features similar to low-grade DCIS and tubular carcinoma. We'll see a little more about that. So what do we do if we get a columnar cell lesion? For columnar cell lesion and hyperplasia, which we often see, there's no further treatment required. For flat epithelial atypia, if you're diagnosing it on a core biopsy, you have to look at the radiology again. Is there anything worse on radiology? Because 30% of them are associated with more sinister lesions. So there should be follow-up, and there should be excision if there is more sinister. This is one kind of classification for intraepithelial lesions of the breast, but this is not regularly followed anywhere, but some authorities use this. So you can, I just put it here to show you the increasing risk of malignancy. Flat epithelial atypia comes first. That's around 3 times something. This is 3 to 5 times. Low-grade DCI is 8 to 10 times, and the risk becomes much higher as it goes up. What's a molecular pathology? So, usual ductal hyperplasia has very low frequency of loss of heterozygosity. There is no specific genetic alteration in usual ductal hyperplasia. It's a benign proliferation. Low-grade cancers have loss of chromosome 16q. That's the most common one that is described, and they're usually diploid. Whereas high-grade DCIS and high-grade breast cancers are aneuploid, and they do not have deletion of 16q. So that is why they consider this as 2 different type of tumors. Low-grade cancers, because they stay long, they don't become high-grade. That's a completely different pathway. And in the low-grade cancer precursors come flat epithelial atypia, lobular neoplasia, low-grade DCIS, tubular-lobular carcinoma, classic invasive lobular carcinoma. So all of them have at 16q deletion, and they're called the low-grade breast neoplasia family. And these, all of these can occur together. So often when you see a low-grade DCIS, you may get lobular neoplasia there, you may get flat epithelial atypia. If you look carefully, you can find that. Sometimes if you look at the tubular carcinomas, they're not very common, but if you get a tubular carcinoma and you look around, you may get lobular neoplasia or a flat epithelial atypia. So these lesions occur together, and they have a similar, they are diploid, and they usually have a 16q loss. So they consider the low-grade breast neoplasia family. So we already discussed this. Now, I just want to discuss micropapillary hyperplasia and carcinoma. So micropapillae means papillae without fibrovascular cores. And this is hyperplasia, where you get proliferation of cells. They form small papillae. And often what you see is that the tip of the papillae is narrower or pinched out appearance, whereas in micropapillary carcinoma, you get, I just show you the picture which I showed. See that? First thing to note between micropapillary hyperplasia and carcinoma is that micropapillary carcinoma is a hugely dilated duct. So that's one point we should remember. Whenever there is intraductal proliferation, the cells can either fill up the duct and form a solid mass, or it can dilate the duct. So when you have a hugely dilated duct which has got proliferating epithelial cells, not flattened epithelial cells, you have to think, could this be a malignant proliferation? Of course, you can get cystically dilated ducts in fibrocystic disease because of the fluid collecting within it, but there you get lining epithelium which is flattened. So, I mean, that's just one point, not that you have to go by it alone, but in this case, you can see this is a micropapillary DCIS, and you've got a hugely dilated duct with a lot of micropapillae, and look at this, the tip of the papillae is broader than the base. So that's also a sign that this is it's a carcinoma. Whereas in a hyperplasia, the tip will be sort of pinched out and narrower, and the cells are so cohesive, they all sort of stick with each other. And you can see in micropapillary carcinoma, you'll see these cells coming out as small, because of the disc cohesion, you can see small cells lying around in the papillae. This is the club, it's called the club-shaped papillae. You've got the edge, the tip, which is broader than the base. So that's about micropapillary DCIS and carcinoma. So that's about, micropapillary hyperplasia versus carcinoma. So I've reached the end of my talk. I would, if there is time, I can show post-test. Is there time?
Sure, ma'am. Sure, ma'am.
Okay. So this is post-test. It's not the same cases because I discussed the same cases while in the talk. So let me just ask, what do people think of this? There are multiple, there are one or two more pictures coming. This is, of course, a dilated terminal duct. There's a lot of cells within it. So we are looking for polarization. We're looking for streaming. We are looking, is it monotonous?
People have replied, ma'am.
People have replied?
Shall I read out the responses?
Yeah.
UDH. Sure. Like UDH.
Everyone's calling it UDH?
Yeah, yes.
So that's one thing we have to remember. You have to watch it all the time. I discussed only UDH and DCIS. This does not show features of either, actually. What is the first thing you're seeing here? This is marked discohesion. All the cells are separate from each other, and you can see intracytoplasmic vacuoles. So now do you want to change the diagnosis? They're not cohesive at all to call it UDH. The cells are LCIS, very good. This is lobular neoplasia. So that's other thing which can mimic a DCIS. So we should, though I discussed UDH versus DCIS, and this does not have features of DCIS, but does not have features of UDH either. This is a very discohesive population with intracytoplasmic vacuoles. So this was a lobular carcinoma in situ. So that's one thing you have to remember when you see intraductal proliferation. And how do we differentiate it? Loss of cohesion is very obvious in LCIS, whereas in DCIS it's minimal. Intracytoplasmic vacuoles are common in LCIS. In the ducts, I didn't show a picture of that. Pagetoid duct involvement can be seen. That means you see these same cells growing beneath the luminal cell in the duct. And you don't find the SNR formation of the DCIS here. That luminal differentiation is not seen. Polarization is absent. So this is one of the mimics of DCIS. This is important to differentiate. Suppose you have a tumor which does not have an invasive component. It's all in situ. Why is it important to differentiate LCIS from DCIS? DCIS is an obligate precursor of malignancy. LCIS is not. So if you get LCIS, there is no need for an excision, complete excision, if the radiology does not show any worse disease. Whereas in DCIS, complete excision with clear margin is mandatory. So when you get a wide local excision and you get LCIS at the periphery of the margins, it's actually, they don't even go back to do a resection. Whereas DCIS at the periphery, at the margin, will require re-excision. So it's important to differentiate. Here we are talking about the classic LCIS. If there is the high grade, the pleomorphic LCIS, they usually treat it like DCIS. Now this is case 2. Does anyone have a diagnosis? I already said it's a mimic. It's not, it looks very polarized, and nobody will think this is UDH or, nobody will think this is usual ductal hyperplasia. This looks very much like a DCIS with polarization and central lumina or whatever. So has anyone put it in the chat? This is another mimic of DCIS.
Someone says collagenous spherulosis.
Yeah, very good. So this is a condition called collagenous spherulosis, where you get flattened myoepithelial cells and luminal cells around base membrane material. So the lumina will have a fibrillary or basophilic kind of material in the center, or sometimes even eosinophilic, which is basement membrane protein. So this can mimic a DCIS. So collagenous spherulosis, there's pink or blue base membrane protein. Here usually it's empty. The lumen, we saw so many pictures, all of them have empty lumina or debris or detached cells. So this is fibrilla or spherule-like. And the cells, if you have a doubt, you can do the myoepithelial cell marker. All of them will stain for P63. All the cells, like around each of these, because actually the myoepithelial cells are associated with the base membrane. So, it's produced by the myoepithelial cells. So you get a lot of myoepithelial cells all around. So this is another mimic of DCIS, low-grade DCIS. I think that's all I have. So I'm happy to take any questions.
Forum is open for the questions. If anyone wants to ask any question, they can unmute the mic and ask, or else you can post it in the chat box. I shall read it for you.
I can't see any questions. So,
Soumya ma'am, you want to, could you please say some?
Ma'am, it was very nice presentation, and each and every aspect of it, right from the cell border up to the nucleolus, you showed the differences between the individual entities. It was very useful, and even for day-to-day reporting also, it is a very, very useful criteria to follow. Thank you so much.
Thank you very much. There's one question here. The pagetoid duct involvement, unfortunately, I don't have a picture. You can just put it on the net, you'll easily get. What you see is this LCI cells under the luminal cells. It will go on as a line under the luminal cells. So you will think, oh, are they myoepithelial cells like that? But they will have the discohesion of the LCIs.
There's one
question is
myoepithelial cells.
How to differentiate basal and myoepithelial cells. Now, normal breast, the myoepithelial cells are the cells, there is, of course, normal breast, there is luminal and abluminal cells. The abluminal cells within the terminal duct lobular unit is called the myoepithelial cell. That is where they are myoepithelial. So the cells outside the luminal cells within the lobules has the function of contraction to express the secretions, which is produced in the lobule. So those are myoepithelial cells. They have a myoepithelial configuration and they have got a contractile property. The abluminal cells within the ducts do not have that contractile property, and they are called the basal cells. So the uncommitted primitive cell which we see is usually the basal cell, because they're lining the outside of the ducts, and even in the lobule you get some of them, but there are myoepithelial cells as well. So now how will we differentiate it? Now myoepithelial cells have, we usually stain it. Morphology wise, very difficult to say. Basal is an uncommitted cell, so it usually does not show any particular property. It's like a UDH cell. Whereas myoepithelial cells, when we see them, they are either spindle shaped, or they have that clear cytoplasm, round cells with clear cytoplasm or pale cytoplasm. Now, to be sure whether it's basal or myoepithelial, you have to do markers which can help, but often it's of no use to differentiate them. So basal cells will stain for CK fiber 6, which is a high molecular weight cytokeratin and seen in uncommitted basal cells. It can be positive in myoepithelial cells also, but myoepithelial cells are a little more differentiated cells. So the marker we do for that is P63, which is a nuclear stain, which I had shown you one picture, and also SMMHC, which is a very specific marker. Smooth muscle myosin heavy chain is a specific marker for myoepithelial cells. They also stain vessels, but they usually do not stain fibroblast. So that is one of the things which we have a problem if we do an SMA. SMA is the most sensitive marker for myoepithelial cell, but then those fibroblasts will also stain for SMA. So what people advise if you want to pick up myoepithelial cells is to do two markers, SMMHC and P63, one cytoplasmic, one nuclear. That's the combination we use. There are other things which you can use like calponin, P40 and other things, but they all myoepithelial differentiation. To look at basal cells, which is a relatively uncommitted cell, the only marker we use is CK fiber 6 or high molecular weight cytokeratin. So that's what we look for in UDH. We are not looking for myoepithelial cells in UDH. We are looking for cells which are proliferating. They are not committed towards any lineage. So you do a CK fiber 6, and you'll see that some of them have CK fiber 6 and others are, sort of differentiated towards luminal cells. So they will not have CK fiber 6. Luminal cells will stain for low molecular weight cytokeratin, that is CK7.
Whenever there is so much of desmoplasia, and especially when we are giving the margins of the tumor, and we are looking for that ductal carcinoma in situ component in the adjacent zone. So if there is so much of desmoplasia, is it always mandatory to go for IHC to see the presence or absence of the myoepithelial cells, or the morphology itself is sufficient? Because we have a difficulty when there is a desmoplastic reaction. It's very difficult to differentiate them from the myoepithelial. So how do you?
So basically we don't do myoepithelial cell marker for every time to check whether there is invasion. Actually, good sections, serial sections to look for individual cells which are in the stroma. If you don't see that, usually we don't do unless you have, you have a doubt whether this is a whole large thing is invasive. So to look for micro invasion, we don't do P63. But to decide whether some of these large lobules are invasive, some of the invasive customers sometimes mimic like a DCI, they are less large round nodules, then we'll do. But to look for micro invasion, we usually just do serial deepers. That helps.
There's one more question. Please explain the salient features and differentiating features between micropapillary hyperplasia and carcinoma.
I'll just show you that. I think I skipped that slide. Do we have time? I don't know.
Yeah, we have.
Can you see this?
Yes, ma'am.
See this?
Yeah.
You can. So micropapillary hyperplasia, the terminal duct lobular unit is not very markedly distended. Whereas in carcinoma, micropapillary DCIs, it's greatly dilated. That is 10 times normal usually. Micropapillary and micropapillary hyperplasia have similar shape and heights. And because they're so cohesive, it's a hyperplasia, they do not, there's no cell coming out of it. So you'll find no sloughed cells in the lumen. Cells and nuclei look like UDH. And the other thing is the tip of the papillae is narrower than the base. And because it's a cohesive cell, the nuclei will sit adjacent to the base membrane, or the cell membrane, not base membrane, cell membrane. Whereas in a carcinoma, you still see that polarization a bit, so that there will be an apical compartment still present at the tip. And as I said, cells at the tip are smaller and more darkly staining nuclei. I'll just show you that picture. See that here? So this micropapillary hyperplasia is often seen in gynecomastia. That's where we most commonly see it. And so it's also called the gynecomastoid hyperplasia. So cells at the tip are darker, just like the maturation we saw in the UDH. The tips are smaller, darker, more condensed kind of cells. Whereas here, this is carcinoma. You can see the nucleus still rounded. Apical compartment is not very well seen here, but you can see the nucleus still rounded. And there's a lot of discohesion. Some of these cells are coming out, whereas here you don't find that. So those are the features which will help you between carcinoma and hyperplasia and with the micropapillary pattern.
I think these are the questions. So I think there are no any other questions. So thank you, ma'am. Thank you for an
Thank you. Thank you very much. Thank you for calling me. Thank you.
opening.
Thank you, sir.
Thank you, ma'am.
Thank you. Bye.
Thank you to all the delegates who have attended this session. So hope to see you soon again tomorrow at the same time between 11 to 1 for 2 more interesting sessions. Thank you.